afternoon and thanks for joining us. I'm Judy Simpson. There are more than 100 types of cancer. Not all cancers are created equal. Some are more deadly than others. Lung cancer is the top killer cancer in this country. So today, as part of our ongoing partnership with the University of Vermont Cancer Center, we're going to discuss lung cancer with two experts. Dr. Gerald Davis and Dr. Matthew Kinsey are both members of the Cancer Center and the UVM Department of Pulmonary and Critical Care Medicine. They have some important information to share with us, and they're going to discuss the screening and treatment options available for lung cancer. Welcome to both of you. Let's start out with some background information. How common is lung cancer, Dr. Davis?
Well, lung cancer is the single most common cancer that occurs in men and women. We know that in the current year there are going to be more than 200,000 new cases of lung cancer nationwide, more than 500 in Vermont. And in terms of deaths per year, this is it's the leading cancer killer. There are going to be almost 160,000 deaths nationwide, and we expect to see close to 400 deaths from lung cancer in Vermont. So it's a very common problem. And
according to that slide that we're seeing too, it's a sort of equal opportunity, 50-50 men and women.
It really is. It used to be predominantly a disease of men. Unfortunately, women have caught up. The rates of lung cancer have gone down in both men and women, but nowadays, particularly in Vermont, it's a 50-50 proposition.
So what are the risk factors of lung cancer? And the biggest factor, as you know, is one that we all know about: cigarette smoking.
Yeah, you're absolutely correct. So exposure to tobacco smoke, whether through a personal history of smoking or through secondhand smoke exposure, is one of the greatest recognized risks for lung cancer. Now that said, about 15 to 20% of lung cancers will occur in individuals who never smoked, which makes it exceedingly common even in people who don't have a smoking exposure. Other important risk factors include exposure to asbestos, which carries a risk for lung cancer in addition to mesothelioma, which is recognized. And I think in Vermont, it's important to also acknowledge the risk associated with radon. Radon is a naturally occurring radioactive gas present in the soil, and it gets into a lot of homes in Vermont and carries a risk for lung cancer. The good news about radon is it can be detected. You can get a free detection kit from the state, and radon mitigation systems can be installed to keep the level at that which is considered safe.
Right. And so let's talk a little bit about addiction and how that sort of fits into this whole picture.
Yeah. It's an interesting problem, particularly with regard to cigarette smoking. We had a long history in this country of accepting cigarettes and embracing cigarette use, I think, before we fully realized the adverse health effects. They were handed out at meetings of the American Medical Association. They were packaged in the MREs of our soldiers and GIs. And I think we've come to realize the ill health effects subsequently, but after creating a large group of individuals who are use cigarettes, and partially due to the very high addictive potential of cigarettes.
And so now not all lung cancer is the same. It's not just one disease. Is that right?
That's absolutely correct. So lung cancer is generally classified into two groups, two main groups: small cell lung cancer and non-small lung cancer, based on how it appears under the microscope. And that's really what you see at the top of the slide. There are some other less common types, carcinoid, et cetera, but small cell lung cancer and really non-small cell lung cancer are the most common groups. And those, in addition to looking different under the microscope, have different prognoses and are treated differently.
And so what's the outlook for someone who's diagnosed with lung cancer, Dr. Davis?
Well, it varies a lot on what stage of disease they present in. If somebody's detected very early with a small, very localized lung cancer, the outlook can be really good. We can expect upwards of perhaps more than 3/4 of those patients, perhaps even as high as 85%, being alive 5 years after their diagnosis if they've had successful surgery or treatment of a very small lesion. As we deal with larger lung cancers and more advanced disease that have spread beyond the place where it started to the lymph nodes at the center of the chest or outside the chest to metastatic sites, the prognosis gets much worse, and survivals are measured perhaps in terms of several years with active treatment or less. So it depends a lot on when you find it.
And so, Dr. Kinsey, what treatments are available for lung cancer?
There's a number of treatments that are available for lung cancer, and as Dr. Davis had mentioned, it's largely dependent on the stage at which the cancer is identified. So, for instance, lung cancer that occurs in a region of lung and only is present in that area, meaning it doesn't involve those lymph nodes towards the middle of the chest or any other sites in the body, can be effectively treated with surgery or with an intense radiation therapy. Cancers that have spread further, either into the lymph nodes or other sites in the body, can be treated with chemotherapy and occasionally with the addition of radiation as well. And I think one important piece to remember is that in patients who can't be cured from lung cancer due to the advanced nature of the disease, treatments are really focused on palliation or managing symptoms and maximizing patients' quality of life. And we work closely with our palliative care colleagues. That can involve radiation, therapies from inside the airways to control blockage of airways and allow people to breathe comfortably. But again, we spend a lot of time focusing on making sure that we can maximize quality of life in patients who unfortunately couldn't be cured from their lung cancer.
So we have screenings for cancers like breast cancer, colon cancer, prostate cancer. What about screening for lung cancer, Dr. Davis?
Well, that's really one of the exciting things, and I think the good news that at last screening for lung cancer has become a reality. It's now advocated by the Preventive Services Task Force of the Centers for Disease Control, by the American Cancer Society, the Lung Association, and many other agencies. Let's talk a little bit about who, how, where, and when.
Okay.
Who really are the people who are at high risk? Because as the risk goes down, you get more and more false positive results in screening, just as in mammography or any other type of screening. So the people that we really focus on are individuals who are between the ages of 55 and 80 years, who have been smoking a total of 30, we call it pack years. It means 1 pack per day for 30 years, or if you smoke 2 packs per day, 15 years. You can do the arithmetic, but a pretty heavy smoking exposure, and who either are current smokers or who've stopped smoking within the last 15 years. And that's really an important point because risk goes on. It doesn't stop the day after you stop smoking. It goes on for many years afterwards. Screening is done with a low-dose CT scan. It's only a little bit more radiation exposure than would be involved in a plain chest X-ray or a high-altitude airline flight across the country. It's a bit more than that, but not huge. It's done, it only takes a few seconds. You can see in the top picture, there's someone lying on the table, and they're going to move through the donut in a couple of seconds to acquire the scan. And what we're looking for is shown in the lower picture. It's essentially a spot. You can see it there in the lung with a red line going towards it. So that's how it's done. And lung cancer screening is now available at UVM Medical Center. We were one of the first sites in the country to receive approval from the College of Radiology and certification, but it's becoming increasingly available and hopefully will be available at local hospitals in the near future. It's recommended once a year and more frequent follow-up if an abnormality is found.
Is it safe to say that lung cancer is largely preventable?
Largely, yeah.
Yeah, not completely, unfortunately, but yeah, I think again, smoking cessation is the most important thing that we can do, and working with your physician, your primary care physician, are important pieces to do that. And there's a number of therapies, medical therapies, that can assist in smoking cessation in addition to nicotine replacement.
Absolutely. I mean, I think that, you know, if you don't smoke, don't start. If you are smoking, please stop. And there's a lot of help available with the addiction part of smoking, as we've touched on.
And also secondhand smoke too. If you're a smoker, you might want to quit, not only for yourself, but people who are around you.
Particularly for little children.
Yeah.
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 And so, are there promising developments being made?
Yeah, I think there are at this point. I think some of the most encouraging come around the development of what we call targeted therapies. These are drugs that are designed to treat specific genetic mutations that are acquired by cancer during the process of becoming a cancer, so to speak. So these aren't genetic mutations that are passed on from parents to children, but ones that the cancer has kind of picked up. Unfortunately, at this point, those only represent about 10% of all lung cancers, but every day we're finding new mutations that may be targeted further. And I think we're getting better at treating lung cancer using local therapies that can avoid some of the systemic toxicities of chemotherapy and drugs given through the vein. So we do more through the airways. And then I think the third piece is really getting better, as Dr. Davis had said, at identifying people who are at risk. And what do those risk groups look like? And can we use other methods beyond CT scanning that overcome some of the limitations of CT scanning and mammography to really accurately predict who has a risk for lung cancer?
I mean, we always hear the cases, too, of people who are non-smokers who get lung cancer.
Right.
Which is a scary thing.
Well, it is, and as we've said, 15 to 20% of lung cancers occur in never smokers, and we need to. That's one of the areas where we need perhaps a less expensive and less invasive screening tool that could really be applied to a larger segment of the population where they have risk, but it's less than for smokers.
So you don't recommend that people just panic and insist that they have these tests done?
No, absolutely not. There are. I mean, there's a downside to screening. not only a dollar downside, but also a risk downside. Most abnormalities found on CT scans turn out not to be a lung cancer, and therefore most people have become worried, frightened. Their families are worried. Their doctors are worried. Even though it really isn't a cancer, but you don't know that until you follow it or you biopsy it. And following it or biopsying it involves additional cost and additional risk. So we really have to balance the risks and the costs against the benefits.
Where can people get reliable information about lung cancer if they're interested in finding out more about it?
Yeah, there's a number of pretty good sources. The American Cancer Society has a nice webpage, the American Lung Association as well, and the National Cancer Institute all have very developed websites that can provide a lot of information for lung cancer. And I think we're going to post those, or they're going to be available on the website as well.
Okay. And also, too, for people who maybe want to quit smoking?
Yeah, there's a number of other good sites and areas to gain information around those as well. The uvmhealth.org has a developed site. 802 Quits is another site, and there's the Vermont Quit Network. All have very well developed websites and a lot of information for assisting in quitting smoking.
And we're talking about smoking and how years and years ago it wasn't seen as a health risk. Well, now the big thing is the e-cigarettes, and I guess we're sort of here with e-cigarettes the way we were back when original cigarettes were given out. We don't know what the health risks are. That's the problem.
We really don't. I mean, we know, first of all, that they have a lot of nicotine in them, so they're still addictive. Number two, and they have the adverse health effects of nicotine on the cardiovascular system. Number two, we know there's a lot of carcinogens in what people are breathing in, but it takes a long time for lung cancer to develop. These are a new thing on the available, a new kid on the block. We don't know the incidence of lung cancer from e-cigarettes, and it's going to take 30 or 40 years before we do. And I hope they won't be around that long. And the third thing is that there's the unknown. We don't know what health effects they may cause that regular cigarettes don't.
Right.
So I think we have to be very careful with those.
Do we have time for about a final word, Dr. Davis? What would you have to say to people who want to know about lung cancer?
Well, we know how to prevent it, at least 80% of the cases, which would be a huge impact.
Right.
But it takes a tremendous amount of political will to prevent smoking, to help people stop smoking, and it takes a big commitment on the part of individuals to not start smoking, to resist the peer pressure when they're kids, or to stop smoking once they've established it. We also now know how to screen for it. We need to much improve screening so that we can do it more easily, less expensively, but we have it and it works, and so we really need to upgrade the programs for screening.
All right, well, I want to thank you both for joining us today.
Thank you.
Thank you, it's been a pleasure.
That's our program for today. I'm Judy Simpson. We'll see you again next time on Across the Fence.